Thank you for joining us. Welcome to Reaction. David Davis, MP. Very keen to talk to you about vitamin D. Now, it looks as though vitamin D might have a critical role to play in fighting COVID-19. What's the history of this?
Well, vitamin D was the last of the four best known vitamins discovered. It's wrongly named, really. It actually should be called a hormone because it's made in your skin. When you go out in the sun, ultraviolet B, one of the radiation frequencies, make it in the sun. So you go out in the sun in the middle of summer and you sunbathe for half an hour, you get about 20,000 international units of vitamin D in your system as a result of that. And it was always known in the early days of its discovery as being important to prevent rickets. I mean, rickets was, for us, the sort of creation of the Industrial Revolution. It was known as the English disease, although it occurs in Scotland too, quite severely because of the latitude. And it was discovered the early part of the last century, and greater and greater understanding of it came about through the course of the last century as techniques and technology advanced. But it was always thought to be just about rickets or osteomalacia, the adult form, or osteoporosis, the elderly form. And then in the 1980s, the early 1980s, it was discovered that it had a big function, not just in bone formation, but also in immune system. The activity of the immune system in all sorts of different ways. It turns out if you have sufficient concentration, it switches on over 1,000 genes, in fact, thousands of genes. It makes them work. It intervenes to limit and modulate inflammation, the famous cytokine storms, those sorts of things. All of that began to be discovered in the 80s and 90s. And the result, of course, is you now have two generations of doctors, those who went to medical school before this became common parlance and think of it as rickets and only rickets and very low doses, and those who went much more recently who understand it's got an immune function to it too. So that was the background, and it was understood before COVID came. In fact, back in 2017, there was a big article in the BMJ about how vitamin D concentrations in the blood and vitamin D supplementation had an impact on flu and pneumonia and colds, basically all winter respiratory diseases. And it was quite a big effect. If you were deficient in vitamin D and you took supplements, it could reduce the symptoms by about 70%, 70%, so a big impact, right? And that was known in 2017, and that was the result of 25 different random control trials, and it was clearly cause and effect. It was actually taking a supplement. It wasn't just measuring how much vitamin D you had, so could have a reverse causation. It was clearly cause and effect. So that's where we got to by 2017, and it was taking time to make, as all things do in medicine, it was taking time to get into the common understanding. And then along comes 2019, 2020, and the COVID-19 crisis. And early on, in the first 3 months of 2020, some people noticed that there seemed to be an association between vitamin D deficiency in the blood of patients and the morbidity, well, the infection rate, first off, the susceptibility to infection, and the morbidity and the mortality. And I've given you a couple of figures 1 and 2, which sort of show this. And figure 1 shows how serious the illness is. So the right-hand side is low levels of vitamin D in the blood and high levels of seriousness, the various grades of seriousness. And then you go from 25 to 50, and then you go above 75. You get nearly every illness caught above 75 nanomoles per liter in your blood. It's minor. Nearly all of them are minor. Very, very rare serious ones, but minor. And figure 2 was done at another Pacific Basin country by another research team, and it showed that the mortality rate sort of fell off a cliff above a certain level. It drops from 80s and 90% to about 2%. Now, I didn't trust this, to be honest, when I first saw it back in March. I thought, one look at it and thought, there's a mistake here. It must be that there are not many people in the over 75 group. But basically what those two graphs showed or indicated was a big association, and at this point just association, not cause and effect, association between low vitamin D levels in the blood and very poor outcomes, high levels of infection, high levels of seriousness, high levels of mortality in COVID-19. So people like me start to say, well, is this cause and effect? If so, is this a nice, cheap and easy way to reduce the seriousness of the illness, either when you caught it or even to reduce your likelihood of catching it?
Yeah.
And so round about that, and I wasn't the only one. I mean, the head of the biochemistry department, I think it was in Northwest University in the States, a big university, they did a big 10-country study, showed the same things. There were quite a lot of studies coming out, some based in China.
You immersed yourself in the papers that were being written about this and the various studies. Tell us about that study, for example, in the US, and there was also a big study in Israel.
Yeah, well, before we get there, just one thing, Ian, and it's this. Around about May, I wrote to the department and said, have a look at this. You can't be sure, but it looks like it could be a very good, cheap and safe, because it's low toxicity, safe way of dealing with this. So that was the point then, that over the course of summer, I read, strictly since January, I read over 100 papers on this, and they pretty much, not all, but the massive majority point in the same direction. And one of the questions was this causal or was it reverse causal? In other words, did having COVID-19 seriously reduce your vitamin D levels in your blood? It's not impossible. It's a sort of hormone type chemical. It could get used up, either way it would say it was implicated, but never mind. That was the sort of kind of, so what I was looking for were things which measured vitamin D, as it were, before you got the disease. And there was a study in the States, they found 190,000 people from health records, commercial health records, I think, who had vitamin D levels measured in the recent past. So you knew whether or not they were vitamin D deficient. Not perfect, because it wasn't at the point of catching the illness, but just before, so at some time before. And what they found was that as you dropped from deficiency to sufficiency, which is quite a big move, 4 times the concentration, your propensity to get infected drops away. And this is figure 3 that I gave you. Now, just so they know, the units are slightly different from the old graphs, which was nanomoles per litre, to this one, which is nanograms. One's 2.5 times the other, but never mind, the graph is the same. And what you see on figure 3 is that as you go from deficiency below 20 to sufficiency at 50, the likelihood of getting infected drops away. It drops away, and then it flattens out because you've got enough in your bloodstream. And so what that fits is the immune model as well, that this is somehow supporting the immune system, that you catch COVID-19 and get it badly if your immune system is compromised. It can't switch on. And all the theoretical data behind it says that. All the theoretical data says it affects the innate immune system. That's the one that protects children before they got any antibodies. And the adaptive immune system, the one that creates the antibodies, both of them require vitamin D to be switched on properly. And what this shows is this really quite strong relationship. And now this can't be reverse causation, because this is measuring vitamin D before they get the disease. All right. And there was another study in Israel. Now, Israel's interesting. Israel's a very sunny country. But nevertheless, within it, there are population groups who still have serious vitamin D deficiency. Orthodox Jews, they wear black, all-encompassing black garments, big broad-brimmed hats, big beards, and so on. Very little of their skin is exposed. They are typically vitamin D deficient, or very often vitamin D deficient. Similarly, Arab women, again, completely covered up. And so you've got groups in Israel which stand out, And you can pick groups which are, as it were, all of the community is vitamin D sufficient, and other groups, all of the community is vitamin D deficient. So it's a really interesting, and it reinforces exactly what the American study showed. That was 1.3 million, of which about 50,000 plus caught the disease. So for every person who had the disease, they could compare them with 10 other people who are alike in every other respect except their vitamin D deficiency. And so again, the same thing showed up over and over again throughout the whole of the summer. We're getting report after report after report showing the same cause, but now beginning to be causal relationship.
And in the UK, that was, of course, particularly earlier in the crisis, there was a particular focus on the impact of this on ethnic minorities and susceptibility. So you suspect that answers that question as well, with particular relevance to doctors on the front line who were ethnic minorities, were particularly prone to COVID-19.
I mean, and look, there are two arguments about ethnic minorities. One is a not unreasonable one, that poverty and crowding and exposure even is greater for them for various reasons of social problems, if you like. So that's one possible reason. But of the first 26 doctors that died in the NHS from COVID-19, 25 were ethnic minorities, from an ethnic minority background. Now, they won't be poor. They're unlikely to suffer crowding problems. They do suffer exposure problems because they're in hospital, but they will be unlikely to be poverty alone. And that graph I showed you, that figure 3 graph, there are versions of it which show it for blacks and Hispanics and other ethnic groups and whites. And you see the same curve. Interestingly, blacks are higher. So maybe there's a social effect as well, or maybe there's another genetic effect, but there are other effects, but it still applies. And if you've got dark skin, and vitamin D is, for most of us, in most cases, acquired in the summer from sunlight. But if you've got dark skin, it's reduced. Similarly, if you're elderly, it's reduced. I mean, I'm 71. I will get roughly 25% of the vitamin D out of my skin that are 20-year-old with the same exposures. Similarly, people who are obese, the vitamin D gets held in the fat and is not useful to their body. They have deficiencies as well. So all these groups, all of which are COVID-19 susceptible groups, they get infected more, they get infected worse, they die in higher numbers. All of them have got vitamin D deficiency. So that's why, but also because it makes it a bit political, unfortunately, because some people just want to say this is racism, not race, with ethnic minorities. I take the view it could be both, but if you've got a cheap option to save, well, Black Lives Matter, to save black lives or to save minority lives, you should do it and try it out. Anyway, so that's the sort of the background there.
What about the evidence on the trial from Spain?
Well,
which some people contest, but that is the only so far randomized control trial so far. What do you make of that?
Well, let's, so your listeners know, or your viewers know, this is 76 people who had COVID sufficiently seriously to be admitted to hospital, right? That's the control group. This is in the middle of the great crisis going on in Spain, because they had, like Italy, they had a huge crisis like us. And in the middle of it, they took 76 people, 26 of them, they said, they're the control group. We give them all the standard treatments, not the same, by the way, as you get in England, but nevertheless, or Britain generally, but all the same standard treatments as the other group. And then we don't give them any vitamin D. And then it took 50 of them, and they gave them a highly activated form of vitamin D. It's what the liver turns vitamin D into in your system. So it's already sort of pre-prepared to be active. It doesn't take 7 days to take effect. It acts straight away. It's called calcividiol. Anyway, they gave them this, 50 of them. Now, of the 26, the control group, half had to be admitted to intensive care. They got much sicker. And so had to be admitted to intensive care. Of the 50, one had to be admitted to intensive care. So 50% was reduced to 2%, a 25 times reduction in worsening whilst in hospital. 2 of the 26 died, i.e. 8%. None of the vitamin D group died. Now, it's a small sample, and it was what they call double masked. It wasn't a full double blind trial, because the doctors ethically had to know what was being given to their patients. And so NICE criticized this and said, well, it's not double blind and it's a small sample, so it's not, it's indicative, but it's not proof. The truth is, and they said, by the way, the reason it's not proof is because the people who made the recommendations that they go into ICU are the people who know about the treatment. Well, not quite true. That will be true in Britain. In Spain, there's a very tight protocol as why, when and how and why you go into ICU. You've got to tick lots of boxes. And that decision's made independently. And what's more, the vitamin D is given to the patients by the nurses, not by the doctors. It's on the file, not in their head. So it was a very doubtful critique by NICE. But then what happened was MIT came along. The MIT Maths Department decided to have a look at this. It's only, as you say, at the time, the only random control trial in the world. Nobody's better than the MIT Maths Department in the entire world at doing this sort of analysis. What they said? They said the odds of this being an artifact, of this not being a causal relationship, it's 1,000,000 to 1 because of the sheer size of the impact. In other words, MIT are saying this is proof. So it is proof, and I am certain of it. There's now another small random control trial been done in India as well. It's much less sick patients, but it had the same directional effect. So what this says is, remember I said in the first place I didn't believe some of those early graphs. They seem to be too dramatic a change when you got above 75 nanomoles per liter. Well, maybe I was wrong. Maybe they actually are reflecting reality, and it does have such a dramatic effect. So that's why I think this is very important, why it's worth a fight, that this works to prevent you catching the disease. If you catch the disease and you are sufficient, it makes it much less serious. Indeed, it makes it a mild disease. Maybe that many of the people who are asymptomatic or lightly symptomatic are people with high vitamin D levels. We don't know that. I'm speculating now. And of course, it means the death rate is higher. Why? Because your immune system is compromised by the absence of this critical hormone in winter, in Britain and other places where you cover up.
So you used the word fight there. There is a fight, a discussion ongoing inside government about precisely this.
Yeah, there's an argument. Let's not mince words. There's an argument going on.
And in that argument, some of the professionals say, look, the evidence is not yet fully clinched, that it's insufficient evidence to make this a major strand of national policy across the UK. How do you respond to that?
Well, I say 3 things. I mean, I say, firstly, go back and do your stats, because look at the entire range of evidence. There have been large numbers of reports about this. It's biologically plausible. You've now got causal demonstrations. You've got other things. I mean, I'll give you another example. Somebody did a study on the relationship between COVID infectiousness and the spectrum of radiation it actually creates. Vitamin D in your skin. In other words, sunlight, that element of sunlight, and they found that for every % increase in UVB there was on a sort of almost a month by month basis, you get a reduction in infectiousness of UV. That can't be reverse causation. COVID-19 doesn't cause the clouds. So there are lots and lots and lots of data. That's my first thing I say to them. The second thing I say to them is this: people are dying now. I mean, in the summer we had time. We don't have, people are dying every day now. This is a cheap and low toxicity vitamin or supplement that you can give to people with pretty much zero risk. There are arguments again on this. People say, oh, it's above a certain level, it's toxic. I don't know of anybody who's died from vitamin D poisoning ever. And there have been people who've been given 1,000 times the right dose in the past by accident. So the precautionary principle, we keep hearing about precautionary principle. Why don't we just Give the people in the care homes, the Black and ethnic minorities, people who are morbidly obese, that's not just fat, but very obese, give them the supplement. And if I'm right, it'll cut the death rate. If I'm right, it'll cut the infection rate. If I'm right, it'll take the pressure off the hospitals. If they're right, it'll prevent flu. I mean, it really, those are the options, you know, that's what you're choosing between.
But the weeks are ticking by. We're going into winter, talking about a lot of other measures which seem to be, I don't know, equivalent to causing a recession, equivalent to the financial crisis, or maybe even taking us into an economic depression of some sort. What's the cost of what you propose?
Well, we're talking, if you go the full range, all the groups you need to cover, hundreds of millions, but that's tiny. That's rounding error by comparison with what you're talking about. What's interesting here is you have two types of decision making. On the lockdown, we think it might work. We don't know. We don't have any evidence for lockdown actually working. The dispute about lockdown effectiveness is enormous by comparison with the dispute about vitamin D efficiency. If you applied the same requirements to what they call the non-pharmaceutical interventions, that's lockdown and social distancing and closing industries and so on. If you applied the same requirement for evidence, you'd never do it. Because there isn't that evidence. There's no proof. So it seems to me that there's a sort of a massive internal inconsistency. But I'm not surprised, because when it comes to economic effects, and indeed when it comes to social effects, the scientists are guessing. They're guessing. I mean, we shouldn't mince words about it. This is not known. I mean, let me give you a simple example. The very same people who argue against vitamin D now were the same people who argued against wearing masks back in March and April. And now they tell us masks are mandatory. We have to wear them under certain circumstances. That's how weak the science is in some of these areas.
But this is a puzzling aspect of it. How can it be that there's this, as you describe it, it's something that's relatively cheap in terms of the context of the country running up a sort of deficit of 400 billion this year.
Yeah.
Why is there resistance, particularly within parts of the NHS? Why has this not been jumped on in the last 6 months?
Well, I think partly it's an old mindset. I mean, if you go back to before COVID arrived, and you read the sort of Public Health England recommendations on dosage levels and so on, they say you should take vitamin D in winter, but the dosage levels they're talking about are off the edge of these graphs. They're so low because they're just about bone health. They're about rickets and osteomalacia and osteoporosis. They're not about the immune system. It's very antiquated, I'm afraid, the mindset. And when people have spent the last 10 years saying do this, it's quite a big emotional jump to say, oh, do that. I was wrong for 10 years. Yeah. And in essence, I guess it involves an admission of error in the past, because actually COVID's a wake-up call. We should have been supplementing our population if we're trying to stop. Remember, before this year, every winter we had an NHS crisis. What caused that NHS crisis? It was caused by flu and colds and pneumonia, pushing particularly elderly people into hospital. We could actually mitigate. We can't stop it. This is, people talk about silver bullets. It's not a silver bullet. It won't stop it, but it will mitigate it. And it's a very cheap way of mitigating it. I suspect the third reason, and it's the reason that infects me too, infects as well as affects. And it's this: for the last 20 years, the supplements industry, that which sells your vitamin D pills and your vitamin C tablets and your B12 pills and all these other things, actually those things will work, but they've overclaimed. They've massively overclaimed on all sorts of things. People who go to gyms take this sort of stuff. People who are worried about this illness take that, and so on. And they make claims for which there's little or no evidence. And the best you can say about these supplements is they're harmless. They might have a placebo effect if you take them, And doctors are quite properly they're brought up to be scientific, and they're very nervous of this industry. And I don't blame them. I am too. You know, I don't want to become the member for Holland and Barrett. You know, but the truth is they're suspicious of it, and rightly so. And I also expect one other thing which we forget about in the midst of all this: they're overwhelmed by work. You know, I mean, I've had the luxury, frankly, stuck in my house during lockdown, unable even to go to Parliament except via video link, because I'm theoretically a shielded person. It's ridiculous, but there you go. You know, I've read all these papers. I don't suppose anybody, frankly, in the advisory team has had the time to read over 100 papers. So there's that as well. So there's 3 or 4 different possible reasons. But the truth is, people's lives are at stake. We should use the precautionary principle. And prove me wrong. I would be delighted, you know, if they do this, and at the end of the winter, it's not stopped any COVID-19, but it has stopped a lot of flu. Okay, I've been proven wrong. That's the only risk. You know, you're going to reduce the pressure on the health service in other ways, not this way. But you know, actually, I don't think it's going to happen. I think the truth is, it's becoming very, very plainly a method of improving the immune system generally, but particularly with COVID-19, which appears to strike with people with weak immune systems. Look at it by latitude. Even by latitude, COVID-19 has a latitude gradient. The further away from the equator you get, the worse the illness. Why is that? Because for above a certain latitude, from September through to April, there's no UVB in the day. You can go out, you can sunbathe all day, you wouldn't get any. That's why. So every piece of evidence you look at, every new piece comes in, points the same way.
So what should people who are watching this do practically? In practical terms, the advice, for example, on the NHS website now, I think, is to take tablets equivalent to, or to use the spray, which is equivalent to 4,000 IU. What should they be taking? How should they be taking it?
Well,
and what different...
I'm not a doctor. I think we be very careful about licensing arrangements in the UK. I'm not allowed to prescribe people. But my view on the matter, and people should talk to their own doctors as well. But the simple truth is, look, particularly for the groups who are at risk. That's the elderly, certainly the obese generally, but the morbidly obese. That's a BMI of more than 35. You know, yeah. I say that very carefully because England prop forwards probably have BMIs of 35 and they're not obese, it's all muscle. But if you're fat and it's and BMI over 35, I say ethnic minorities, frankly also some of the comorbidities, diabetes and so on. But the simplest thing is go get a test, see whether your blood levels are high enough. If they're above 75 nanomoles per litre, if they are, then you don't have to worry about it. But if they're not, I think the safe, easy, cheap thing to do is, as you say, 4,000 units. You can get by with a lot less than that. But if you're in a risk group, that's where I would be looking.
And do you think that this is just going to become a natural part of the annual cycle, that people will start taking this in 1st of September or so, and it's just something they do to protect themselves against the winter?
Yeah. I mean, it's common sense. I mean, it's implicated in all sorts of other things. We don't want to waste time on it today, but you know, the oddity in all this, the paradox that proves the case, is the Nordic countries. You know, Norway, Finland, Sweden. They're further north than we are. They're Scotland and north, basically. And the truth of the matter is, they supplement their diet, a lot of fish and oily fish in their diet anyway, but they also supplement they fortify their foods as well. We stopped doing it, incidentally, in the 50s. There's another wonderful throwaway fact.
So we used to do it in the sort of 30s, 40s and 50s. It was in food.
Yeah. It was in the food. And then there was a scare because of a genetic condition for certain children who got hypercalcemia, too much calcium. Too much calcium can affect the health of your arteries and veins. It can also affect things like kidney stones. And I had some children getting hypercalcemia. It turned out to be largely a genetic condition, but nevertheless there was a scare, and so we stopped fortifying. in the early 50s. Interestingly, when were the great big pandemics? Well, the one's famous was 1918, and then there wasn't another one until 1957. And we were fortifying in 30s, 40s, and 50s. So even during a major war, we didn't have another pandemic. So when nutrition would have been an issue. So it's interesting that countries like Norway, Finland, and Sweden, all of whom, by the way, have done better than us. Sweden, bear in mind, with its no lockdown policy, have done better than us. One of the reasons, I think, is higher vitamin D levels. And in Sweden, where they had a no lockdown policy, incidentally, the biggest death rates were in care homes, same problem of deficiency, and amongst Somalis. There's a big Somali community, and of course, used to a very sunny country, again would get vitamin D deficiency because of darker skins. So again, every time you look at it, the details support the basic thesis.
Actually, do you think you're winning with the NHS?
Yeah, I think I'm winning. I'm winning with the political class. I think there's number 10 seemed to be on side. I think Matt Hancock's view, as stated, is look, there's no downside to this. It's not very expensive. Let's try it. But of course, he has to go by the advice he's given by a specialist. So that's where I think the tension is right now. But I think at the end of the day, we will win. The important battle, the next battle is the proper dose, because the doses have historically been given very low, wouldn't make any difference. This, as I say, they're off the graph. We want to get a decent dose. And I think we'll win. I just hope it's soon, because this is a quintessentially seasonal disease. Look at the pattern. The last outbreak here was stopped essentially by the summer. Lockdown may have helped, but the summer stopped it. Same in every other country. And winter's bringing it back, and it'll go on until next May. So the quicker we move on this, the more lives we'll save.
David Davis, thank you very much for joining us.
Thank you.